Hey Cam followers, now this is a live I've been really looking forward to, potentially for about 5 years actually. So please welcome the lovely Professor John Innes to our screens, who is giving up his time and his knowledge for a really, really important live tonight. We're going to be talking about objective monitoring, but we're also going to dabble into something really important that you guys need to know about, which is the pathophysiology of OA, because we need to understand this better so you guys can start making the right treatment plans for your dog. I'm going to let John introduce himself because it's quite long. He's done a lot. He's been here with OA for a long time. So please, John, tell us all about yourself.
Thank you, Hannah. I guess that's code for saying that I'm old. Yeah, I'm a vet like you, and I qualified for, well, 30 years ago this year. So we're having our 30-year reunion soon. And I qualified from the University of Liverpool, then spent 10 very formative years at the University of Bristol. And I guess that the thing that changed my career path really was doing a 3-year PhD in the medical school in the rheumatology unit with a guy called Professor Paul Dieppe. And Paul Dieppe was an inspirational character, is an inspirational character, and he was Professor of Rheumatology. He kind of has changed the human healthcare view of osteoarthritis, and he really inspired me to think about OA as a very dynamic disease, a disease that is not just about getting old, and it's not about wear and tear. It's about active biological processes that we can understand, and actually we can intervene in, and actually make lives better for patients that happen to have the disease. He was also a hostage in the Gulf War for 6 months, and to come through that and still be a very incredibly positive person. So I owe a lot to him, and that set me on a path of kind of trying to understand canine OA much better. And so I spent the next 20 odd years in University of Bristol and University of Liverpool researching osteoarthritis in dogs primarily, and developing some tools and publishing papers along the way. And 8 years ago, I left academia, and I'm now in private practice, and still carry on with some OA research work, but I get to see lots more patients now rather than teaching and doing research. So it's nice to be back in the clinic.
And you're an extremely competent orthopedic surgeon and an extremely competent neurological surgeon. So you do spinal work as well, don't you? So your talents are quite well.
Well, they're your words, not mine. But yeah, I've trained as a specialist, and in those days, I trained in orthopedics and spinal surgery, which is the way that the training programs were put together. So my clinical work is in those areas. Yeah. So
basically, his name is on loads and loads of papers. With him and Lascelles, all the time, they just pop up on all the papers that I'm kind of like trying to skim read as quickly as I can. So we are very, very lucky to have you here. What I really want to do, and I think is really important, and John's agreed to do this, is to try and introduce you guys to the complexity of OA, because something that really gets my bee is when people say, oh, it's just OA. Oh, it's so boring. Oh, it's just OA. And I'm like, oh my God, it's not. There is so much going on. And I think if you guys understand more of the inflammatory side of this disease, I think you're going to have a better understanding of how different medications work, which is really important with the recent release of a completely new approach to pain management. So if it's okay with you, John, I'm going to share your slides, and we can crack on and you can talk to the followers about that. So let me I'm going to just do that. Bring it up again. Here we go, slideshow. I'm beginning. So you just tell me when you want me to push on forward, okay?
Yeah, great. So thanks, Hannah. I just thought I'd share a few slides around the sort of the pathophysiology of osteoarthritis. And I've deliberately put a human knee on there, a person in pain, because I think many of us certainly get to my age, you might start to suffer from osteoarthritis yourself, but you probably, if you don't, you probably know someone that does. And pain is what it's really all about. We we want to relieve pain as best we can. So we'll go on to the next slide. In the interest of transparency, I should declare any competing interests. So, you know, I have, I'm obviously a member of CVS Group, which is a corporate veterinary practice. I've got some track record in developing IP in things linked to OA, one of which was the Liverpool Osteoarthritis in Dogs owner questionnaire, which we'll talk about. So just bear that in mind. And I've done some other things around developing veterinary tissue donation and also developing new implants for orthopedic surgery. And I have done some consultancy for companies like Zoetis and Elanco in the last couple of years. Okay, so I'm going to talk a little bit about OA, what it is, and then a few slides on pain mechanisms, because I think that hopefully will allow you to understand how the science has really progressed in the last 25 years or so. And then some practical things about how we can assess the severity of osteoarthritis in dogs, and then a little bit about the new ways that we can control pain and inflammation. So I won't bore you with this slide. Osteoarthritis is really important in dogs because it's by far and away the most common form of arthritis, but it's not the only form of arthritis. You can see OA on the left-hand side there is in a box on the left, but there are lots of other forms of arthritis that exist. They tend to be less common, but it's always worth speaking to your vet to make sure that it is OA that you're dealing with. The treatment of the others is very, very different. Okay, thanks. There's an arthroscopic, so a keyhole camera view inside an arthritic joint, and you know, that's what we see when we look inside arthritic joints. The white tissue that you can see, the very white tissue, is articular cartilage. That's in the lower part of the image. In the upper part of the image, you can see a sort of pinkish, rough tissue. That's bone, and that bone should be covered with cartilage. So the cartilage has been eroded away, and this is essentially what we call end-stage arthritis. The cartilage has all been worn away, and there is no, you know, that pathology has kind of run its course now, and this may well cause chronic pain. So arthritis is a slowly progressive disease where the cartilage is gradually eroded away, but not just mechanically. There's a biological process that makes it fall apart, essentially. Great. And we've all, you can see on the bottom right of that image.
Oh, do you want me to go back? I'll go back.
Slightly. Bottom right hand, sort of 4 o'clock on that clock face, you can see some red tissue, and that's the joint capsule, so the soft tissue that surrounds the joint, and it's red because it's inflamed. So inflammation is definitely part of the osteoarthritis process. Great, next slide, please. And it's really common, OA. We think about 1 in 5 adult dogs have some form of osteoarthritis. So, you know, that's probably about 2 million dogs in the UK. Really, really common. And, you know, figures for human populations are quite similar. So it's a really important issue. And so it's important to understand it, important to be educated about it, and important to be able to make good decisions about it. And in dogs, I suppose the difference in dogs is that dogs will often develop what we call developmental joint diseases when they're young, such as hip dysplasia and elbow dysplasia. And those diseases occur in dogs that are less than a year of age, but they cause what we call secondary osteoarthritis. So they initiate the pathology of osteoarthritis at a very early age in dogs. And so some dogs live with OA for the majority of their life. It's a bit different in people where osteoarthritis is most commonly affects older people, particularly postmenopausal women, where we see osteoarthritis appear in many women after menopause. And so it's in later life in most people. Not always, of course. People that have injured their joints playing sport or whatever can develop osteoarthritis earlier. Okay, next question. Next slide. So this is a little model I put together to try and explain that osteoarthritis, if you look at the top right of this diagram, is a localized disease, so it tends to affect individual joints. So it's not like rheumatoid arthritis that affects multiple joints at once. So let's say we've got an injury to a joint, and that changes the joint biomechanics, and that will initiate the process of osteoarthritis. But actually, at the patient level, the whole patient level, we've got a sort of predisposition to osteoarthritis as well. So factors such as age, genetics, other systemic factors can influence how fast the arthritis progresses. And so we get tissue damage that causes the release of pro-inflammatory proteins, which are known as cytokines and prostaglandins. And that can cause sensitization of the neurological systems of the pain pathway. And there's a key mediator there, which is called NGF, or nerve growth factor. And ultimately, this ends up in pain. And pain is what is important to your dog. Your dog doesn't really care about what his joint looks like on an x-ray. He's actually bothered about whether his joint or her joint hurts. And it's the same for us as human patients. And of course, pain may then cause lameness and disability, mobility issues, but also behavioral change, and dogs can become a little bit grumpy sometimes. Great, next slide, please. So damage to joint tissues, such as an injury to ligaments or a fracture of the joint or instability of the joint, causes inflammation of the joint capsule, which is known as the synovium, and we call that synovitis. And all of that red tissue on those images is synovitis. And the synovium grows and becomes more florid as that inflammation progresses. That's what it looks like. And this next slide, sorry, Hannah, we'll carry on. This is this really is a very simplified diagram or cartoon of what's going on. The molecular alterations in osteoarthritis are incredibly complex, and tens of thousands of people around the world continue to research those. But in the middle of that cartoon is the cartilage, and there are lots of biological changes in the cartilage when there's an injury to the joint, and there's a change in the enzymes in the cartilage, get breakdown of the tissue, and it starts to fall apart. So mechanically, it's not as good. But as part of that process, molecules are released from the cartilage, which then bind to receptors on the joint capsule, the synovium. So on the right-hand side, you see the cells of the synovium, and they're detecting those molecular messengers. And those cells in the synovium are responding and producing inflammatory mediators, which ultimately lead to pain. And you'll see there, NGF is in that category, and it's NGF is binding to the nerve endings in the joint capsule. And you'll see above it PGE2, which is a prostaglandin, which also is binding to receptors and causing pain and inflammation. So
I love that slide. I really love this slide because it's exactly what I was hoping that you'd get across to the followers, is the complexity. Bear in mind, this is a really simplified slide, but also it gives you lots of hope of all the different areas that we can potentially intervene, and people can start beginning to understand the different mechanisms of the different approaches. I'm obsessed anyway, so there you go.
Well, you're absolutely right, Hannah. And within that, this is very simplified. There's loads more going on, but within that, there are some really important targets. And drug companies have been looking to develop agents against those targets for the last 30 years. And some, obviously, like most drug development, some come to fruition, some do not.
Absolutely.
So when we get damage, we can get binding to a cell receptor, which then causes those cells to produce inflammatory cytokines, as I mentioned, or proteins, including nerve growth factor. I'll mention nerve growth factor again because it's a kind of new kid on the block in terms of targets that we can use in the clinic. So nerve growth factor, when it binds to a nerve ending in the joint capsule, because that's where we sense pain in the joint. It's in the joint capsule, there's no nerve endings in the cartilage. It binds to that nerve ending, binds to its receptor, and that complex of receptor and the NGF transported up the nerve to the cell body of the nerve towards the spinal cord, and then that induces changes in the cell body, which then sends transmitters back down to the nerve ending, but also into the spinal cord, and changes the transmission of neurons or nerve cells within the spinal cord. So the effect of this is to essentially sensitize the nerve endings and sensitize the spinal cord to painful stimuli. So when you've got chronic pain in a joint, it's easier for the nerve endings to be stimulated. So joints that are already painful sense pain even easier. So the whole joint is sensitized, but actually the whole limb can be sensitized. And dogs are feeling more pain, or feeling pain more easily once this whole system is ramped up. So at the nerve ending, the binding of nerve growth factor to its receptor, which is in the middle there, it's called TrkA, causes all sorts of molecular changes, which essentially sensitizes the nerve ending. And we call that peripheral sensitization. But it's also doing that in the spinal cord. So if we go to the next slide, so where the primary nerve cell projects up into the spinal cord, and it meets another nerve cell, which is called a synapse, we're getting changes there and transmitters there, which are sensitizing that area. And we call that central sensitization because it's in the central nervous system. So osteoarthritis is causing changes not only in the joint, but actually in the nervous system at the level of the spinal cord. Okay.
And that's really important that people kind of know that, because I think there's a real tendency for people to only imagine that the pain is emanating from the joint, and it's just a simple light switch circuit of pain, brain. Whereas I think a lot of people don't understand that the nervous system will change and rewire itself again and again and again, to a bit like a National Lampoon's Christmas house, basically.
Yeah. And we've all experienced this hypersensitivity, I would imagine. If you've ever had an injury, that lasts for a little while, it's the lightest touch can cause pain there. And that is that hypersensitivity. It always seems, if you've got a sore finger, it's the first thing that you knock against something else and it causes pain again. And that's because of that hypersensitivity.
Yeah.
And I guess there are also thoughts that with time, you can even, this is a bit of a provocative statement, that you can even cause changes in the brain. And, with chronic pain, we get changes in the spinal cord, but also maybe even higher centers in the brain. So there could be maybe changes. There's quite a lot of evidence in human patients that there's a link between musculoskeletal pain or arthritic pain and depression and other things. And I won't bore you with the details, but there is evidence this occurs in dogs. So here's a paper from the University of Edinburgh Vet School, but they showed essentially with dogs that have a painful knee, their whole limb is sensitized. So actually they feel pain more rapidly in the rest of the limb than they would normally. So there's evidence to show that dogs are experiencing this, as well as human patients, where we know it's well evident.
Yeah, because I didn't know about like von Frey fibers. Can you just explain what these are? Because people are thinking that looks like a crayon set.
Yeah, sorry, they're just a tool that people that do pain research, and that's not particularly me, but people that do pain research, they want to create a stimulus, and so they've got these fibers that create a sort of scale of different stimulus, if you like, and so they're looking for when there's a response to that stimulus, and so that's a way that they measure the sensitivity, if you like. So you mentioned Duncan Lascelles earlier. Duncan and I started our careers together on the same day in 1991.
No way.
Bristol Uni, and we've been friends ever since. But Duncan's research was pain, and he's the person you could really tell you all about this methodology. That's his real strength. Yeah.
Now I saw you two chatting together on a webinar, and you could tell that you had like this good relationship for many years, taking the mickey out of each other. It was fun to watch.
Yeah, absolutely. So he'll probably get me back at some point. But I guess, just end that little discussion by saying that, as vets, often we look at X-rays and images, and we sort of look at the pathology of arthritis and how much damage there is to the joint physically. But actually, from my point of view, it's all the stuff you can't see that's important, which is all of that stimulation of the pain pathways, and it's how much the joint hurts that's important to the patient, not how much change there is on an X-ray. So X-rays are useful tools to give us a diagnosis, but they're not useful in terms of staging the problem and telling us how bad it is. Okay, so I guess, Hannah, I was going to go on and talk a little bit about how we can sort of capture the effects of osteoarthritis on dogs.
Yeah.
And I mentioned that the biology of osteoarthritis is complex, but so is trying to measure how bad it is. And this is again, a very simplified slide. Osteoarthritis at the center of it, but think of all the changes that it induces in our dogs. So they might have reduced mobility, and that might affect them in all sorts of different ways. They might have stiffness after a lie down. They might have a reduced economy of motion, so just moving is more tiring. They can have obvious lameness. They might have difficulty going up and down stairs or doing all sorts of things that you're very familiar with, Hannah. And then on the other side, of course, it's causing all sorts of changes in the body: pathology, inflammation, pain, and pain can manifest in different ways. We know from human patients that if you ask them to describe their joint pain, they will use a variety of different words to describe their joint pain. It might be stabbing, it might be burning, different types of pain, and different types of pain at different stages of the disorder. And night pain is one of those that patients with more advanced arthritis might suffer from. And there is evidence that night pain, pain that stops you sleeping, wakes you up at night, actually also occurs in dogs too. So I think we need to develop our empathy skills when we're thinking about our doggy friends that have got arthritis, because they're probably experiencing exactly the same things that human patients would experience.
Yeah, definitely. And I think you're right saying that, because there are lots of people whose dogs, when during daytime and when there's distraction and when there's things that are going to stimulate the brain to kind of like override pain signals, they're going to look okay, and they're going to engage, and they're going to go for walks, and they're going to chase balls, and they're going to chase squirrels. But then their behavior might change at night, and that still needs to be talked about. I think people find it quite hard to understand that a dog could be in pain even if they're still active during the day. And that's a great slide to illustrate that.
Well, I have to acknowledge Ben Walter for that slide originally, so I've tweaked it.
Good job, Ben. Good job.
Yeah, so this is kind of, that slide is trying to kind of encompass what we might call the construct of osteoarthritis. And we're trying to capture as many dimensions of the disorder as we can. Now, this is a whole science in itself, so we can go on to the next slide. This is the area of patient-reported outcomes measures, which is human healthcare's version. In veterinary medicine, we use pet owners or clients as a proxy to tell us about their dog. So we might call them client-reported outcomes measures. So we're essentially developing tools which are questions that we would ask to patients or to clients, but where the responses can give us the most reliable and efficient information about the clinical status of the patient. And this is a whole science. There's textbooks written on this. There's even a journal, peer-reviewed journal about this in human medicine. It's a big deal in the NHS now to collect patient-reported outcomes measures. So we're a little bit behind in veterinary medicine, but it's accelerated recently. So we'll talk a little bit about this, because this is where pet owners really become involved and partnering with veterinary professionals in terms of deciding how bad the problem is. So we can probably move on to the next slide, I think. So these are questionnaires in their simplest term, but they're not just questionnaires that someone's just dreamt up and used. They've been through a validation process, and some people listening may have completed these sorts of things for their own health, or seen them in GP surgeries, etc. And the questionnaire then produces a score, and it's that score that allows us to stage the problem. Okay. So I won't bore you with the science of validation, but this is all borrowed from the field of psychology, really. And we're looking to make these questionnaires reliable and robust, but also responsive, so that if there is a change in the clinical status of your dog with respect to arthritis, we can measure that change. And if we can measure the change, well, then we can start to decide which treatments work well for your pet and which don't. And also we can use these instruments in clinical trials to decide which drugs are beneficial and which are not.
Yeah, definitely. I think there's they really don't get the attention that they need. And I think people don't realize how valuable they are to detect whether your treatment, which you really hoped was working, actually isn't working, and your pet's still saying, do you know what? I feel exactly the same. And also to preserve your own resources. You don't want to be putting lots of products and interventions into your dog if they're not actually having any beneficial effect. You want to know about that as quickly as possible so you can redirect your resources appropriately. And it's a shame because these tools are available free of charge for people to tap into. It just takes a little bit of time and consideration, and it will be so useful to your vet if you were able to go pre-prepared with these. It's a game changer.
Yeah, they are free of charge, and they're a really useful tool for communicating between owner and vet, and also communicating from vet to vet, vet to nurse, vet to other professional. And they're a good tool for tracking progress as well, because you can store the scores in the medical record, and everyone knows what that means. So they are gradually gaining more traction. They're appearing more in the research that we do around different treatments for joint disease in dogs. So that's fine. I mean, I was involved in developing the Liverpool one. Had this sort of idea back in the mid-90s, and it's taken a generation for it to kind of gain traction in practice. And the same is true of that other one you see there, which is the Canine Brief Pain Inventory, which was developed at the University of Pennsylvania by Dottie Brown. And again, it's taken, since the mid-90s, late 90s, for that to kind of gain a lot of traction. And the nice thing is I'm working with Dottie now to try and continue to refine these and produce more information around these tools that we can use.
Yeah, but I think they're good for everybody involved. Like, just thinking as a vet professional, to have this tool included in your notes and it supports your clinically reasoned decision making, so that you can substantiate your choices. So if anybody ever came back to you and said, well, actually, I don't see that we saw improvement, and I hold you accountable, you can look back and go, well, actually, no, we did see improvement. And this is the progressive nature of the condition. I just think it's beneficial, dog owner and vet, to try and include these.
Yeah, absolutely. I think they're actually a great way to collect information in a standardized, reliable way. So you haven't got the variance of just a discussion. And actually it's very time efficient to do it this way.
Yeah, definitely. And also, if you think, I know the amount of times that I get put on the spot in a situation like being a client in a consult room, and someone says, so how's he doing? You just go, he's fine. It's just like, you just come out with an answer, don't you? Yeah, no, it's fine. Actually, being given the chance to take 5 minutes to really think it through and go in with more detail, hugely important.
Yeah. So, as I say, it was an idea in the mid-90s, and, part-time, it's been a lot of work to work through this sort of validation process. But we've done that, and so as have others. There's an instrument from Helsinki University, there's a Cincinnati instrument, there's a Canine Orthopedic Index. So there's about 4 or 5 of these instruments out there. that can help score your dog's mobility issues. Okay. And for those listening who are really having problems sleeping, you can read read all this science. This is a paper. It's open access, this paper, so anyone can read this paper. And this is how, explains how these instruments are validated. And this is one of those papers, but it's in PLOS One. And if you search for the author names there, Walton and Innes and Lascelles, there he is again, Duncan Lascelles.
He's everywhere.
He's everywhere. And, that you can read all the information there. It's free to access.
Yeah, and I've got a couple of things. I read this one today, and there was a sentence that I just grabbed. For a disease of such importance, I love that. I just had to put that in there. And this other one, assessment of function and pain in chronic disease such as OA is challenging because the disease changes slowly and individual interventions may have only small effects. And I just think the amount of times that I was looking at my own dog, trying to decipher, were we doing well? Were we doing badly? And you can get really lost in it. And these tools can really help you out, clarify what you're seeing and improve that communication with your vet.
Yeah, that's nice of you to say. I think that you're right. They make you focus on individual activities and aspects of the problem, rather than trying to put it all together in your head, and they break it down, which I think is useful.
Yeah, just a little kind of tangent. I know that when I was doing my mobile service, I'd have owners saying, "Oh my God, it's time. It's terrible. It's all gone wrong." And then as the vet breaking it down, going, right, let's look at activity, let's look at sleep, let's look at, appetite, engagement. By the end of that conversation, they're like, it's not that bad. It's in my head. I was getting concerned. And these tools could actually be that kind of vet brain, making you break it down and think logically rather than emotionally. And I was terribly emotional with Holly, so I got her through to 15, 16 years old. And towards the end, I was relying on Gwen Covey-Crump trying to help me think logically, because you just get suffocated in emotion about the situation you're in. And these tools are very good at trying to make you think objectively.
Yeah, I agree with that. I think when it's your own dog, it's very, very different. Yeah. Now, I don't know whether these videos will work, Hannah. This is a bit of fun, really. So this dog here is walking up and down a runway, and just there in the middle of the runway is what's called a force platform. So this is the gait laboratory that I designed at the University of Liverpool, and that's measuring how much force that the dog is putting through each limb as it walks over the force platform. And this has been the gold standard way to measure limb function in dogs for 30, 40 years. It's expensive, relatively expensive equipment, but it is objective, so people believe it, but it does have some drawbacks. So you have to measure each limb individually, and you can see this dog, if we do that, we can then derive what's called an asymmetry index for its hind limbs. And the asymmetry index for this dog was 17.8. So that's essentially telling us that it's lame because it's putting less force through the right hind limb compared to the left hind limb. And then this dog's owner has completed the load questionnaire, and it's got a load score of 13. And you've all seen the dog walk up and down the runway. So try and remember those figures. Asymmetry index was 17.8, load score of 13. We'll then go on to the next slide, and we'll watch this dog. And then back. And you'll notice that this dog on the force platform has an asymmetry index of 15, so less than the other dog. But I don't want to influence your own thoughts here, but if you look at this second dog move, to me, this dog its movement looks laboured. When it came back towards us, its tongue is hanging out, looks tired. It's not as eager to move as the first dog. And its load score is 23. That's the owner's impression of their dog's function, which is higher. So the higher the load score, the more the mobility issues. So I think, if you look at these two dogs, to my mind, the owner questionnaire is giving us a truer representation of the dog than the force platform is. And so this is really a slightly silly way to kind of get across that I think these owner questionnaires are really useful, because they generally give you a very true image of the severity of the problem.
Yeah, definitely.
So, we use the load questionnaire. Others might use other questionnaires, but we use it routinely in our clinic for all dogs that have a lameness problem. And, we know the spread of scores in large populations of dogs with arthritis. So when we know the score, we can put that in context with the sort of population of dogs with arthritis. And it can be a useful way to put things in context and to kind of explain what might be the appropriate interventions at that level of the problem.
Oh,
now,
good. Oh, yes.
I'm going to put a little caveat in here, and Mike Gonzalez is another old friend of mine, and Rich Evans. They work in the States, and Mike's now at the University of Minnesota, and they've looked here at owner questionnaires and force platform readings in a population of dogs that have been given placebo. And you can see that the force platform, the dotted line, doesn't change over time from 0 to 42 days in this population of dogs, whereas the owner questionnaire improves, the score goes down. And this is what's called the caregiver placebo effect. Vets also exhibit this effect, and that's because human beings want things to work. It's a natural thing that we want a medication to work, and surgeons are the same. If they review their own cases always do better than other surgeons would view, and that's just human nature. And this is just representing that. So you've got to bear this in mind, that vets and owners will want treatments to work, and we will be able to measure an improvement on an owner questionnaire overall in populations. And so we're doing some work at the moment to quantify what is the minimal clinically important difference on these questionnaires. So if you're getting a slight improvement, is that significant or not? And I think it's worth all of us bearing in mind that there is a bit of a psychological devil at work when it comes to interventions in OA.
Yeah, I think there was a paper looking at whether people should have access to what they've written before. So like in theory, you would think if people had access to the previous scores, then they would be more likely to let that influence their subsequent scoring. And you would think that would really encourage this caregiver placebo, but I think it didn't show that, which was a surprise.
Yeah, it's a very controversial area. It has been for a long time. I think Duncan did a study to show that actually, if you show previous scores, you actually improve the discrimination between placebo and active treatment. There are some other studies out there in human medicine that suggest the opposite. I think it depends on the context of what you're doing as to whether you should do that or not. But yeah, it's a really controversial. This placebo effect in OA is there in human patients too, assessing their own pain. So up to 60% is the placebo response in osteoarthritis in human patients.
Scary.
This slide is really just to show that whilst the force platform can measure improvement in function in response to medication, so can the owner questionnaires. But the other message from this study, this is a 12-week study that we did comparing two anti-inflammatory drugs for osteoarthritis, and we measured the outcome at 6 weeks and 12 weeks. And whether it's the force platform or the owner questionnaire, the outcome is better at 12 weeks than it is at 6 weeks. So the other message here is about if you've got a chronic pain issue, long-term pain relief gives you an overall better response than short-term pain relief. And that may go back to all of those hypersensitivity changes that I talked about earlier. That with long-term pain relief, you're kind of blocking those pathways and gradually perhaps returning things to normality a little bit.
Yeah, and I think that's such a, God, if there's one thing that you're going to take home today, guys, is this, because being a first opinion vet, knowing that you want to put the dog in front of you on a long-term non-steroidal trial, you've got the owner to contend with regards maybe price point, with the fear of adverse events. And there can be a tendency as a first opinion vet to be swayed to giving shorter prescriptions for fear of owners' response, attitude, etc. And it really can put non-steroidals in a bad light, in that they haven't had the chance to show how good they can be. And so when you see vets that are kind of like giving you 7 to 14 days, and they do it a little bit sheepishly because actually they really want to give you 28 and upwards, get on board with them. Say, that's okay. I get on board with this. I understand that this is going to be a 3-month trial. I just know from my own experience being in practice, there's always that difficult conversation as that vet introducing a medication with a potentially long-term viewpoint on it.
Yeah, it's a good point. I think that is a bit of a barrier sometimes, but these data, and there are other studies out there that show this, that actually it takes 40 to 70 days typically to reach the maximum effect in osteoarthritis with pain relief. So,
yeah, definitely. And it's sad because that sometimes you only have one opportunity with an owner. You shouldn't do, but it is true. And you put them on a non-steroidal, and a week to 2 weeks later they say, "Oh, that really didn't have any beneficial effect." You're like, "No, God damn it!" And they're like, "No, I'm not willing to try any other medications. It is what it is." You're like, "No, that poor dog. We need to really get across to people that it is a longer-term trial period."
Yeah. Okay, so wrapping that up really is to say that these questionnaires can really help everyone involved with managing osteoarthritis in a dog, and I think they help create a care partnership between the veterinary practice team and pet owners, because ultimately we all want the same result, which is a dog that's having a happier life, really. Dogs live for mobility, don't they?
Yeah,
so
definitely.
It's important. Yeah.
Amazing. Let me come back on screen. My computer says no. Here we go. Yay, here I am. That's amazing. Thank you so much. Oh my God, so professional. I don't think Cam's ever been that professional. Sorry to all the other speakers that ever joined us. We've got questions. Should we throw a few questions here? Let's have a look. Ready and willing. Oh, do you know what? That is what you want to hear from an owner, isn't it? Fantastic.
Yeah, very good.
I was singing your praises, guys, to John before we went live, saying that you just are really engaged, always inquisitive, and very supportive of each other, which is fab. Okay, what's this? In practice, how do vets diagnose between OA and rheumatoid arthritis? Most people are just told your dog has arthritis.
Rheumatoid arthritis is quite rare in dogs. We see some, and rheumatoid is a type of polyarthritis, and we see some other types of polyarthritis, but usually the signs are a giveaway, really, and multiple joints are affected at once. You might have multiple joint swellings that come on suddenly. You might have a temperature. You might have swollen lymph nodes. It's more of a systemic disease, and that's usually a giveaway. Sometimes if it's more low key, it can be quite challenging. But that's often how we differentiate clinically. And then there are some diagnostic tests, some blood tests that can help. And getting some fluid from the joint is the ultimate test. If we get some fluid from the joint and get a pathologist to look at the types of cells in the joint, that will differentiate between the two different disease processes.
Yeah, definitely. And again, I think from a first opinion vet's perspective, having owners coming in being receptive that there can be an investigations required is really important. There's too much of the, I think he's got OA from a distance as he walks in, and people want you to kind of resolve the whole problem without having done any further investigations. And in many cases, it's really important that we do. So be receptive to the fact that your dog might need to go in for a day, have a sedation, maybe have an anesthetic, have things done to make sure you get the right diagnosis.
Yeah, and I think that's a really good point, Anna. And of course, the other thing to remember is what I said right at the start, which is osteoarthritis in dogs is often a secondary problem to a primary joint disease. And it may be, with investigations, you might identify that primary joint disease, and there may be a treatment for that, which might be very different to managing the osteoarthritis. So for all those reasons, it's important to be open to investigations.
Yeah, definitely. What's this one? I use Helsinki questionnaire. It's linked to a website I use, which means I can track and more importantly not change the results. Very nice, like it.
Yeah, that's good. I didn't know that. There are other. The load questionnaire is linked to a website in the States. It's not come to Europe yet, but Elanco run a site in the States that people can use, but not available to us in the UK. But I didn't know the Helsinki one was linked to a website. That's really
cool.
Cool.
I didn't. Maybe you can share that with us, Stacey, and let us know. Oh, we're gonna throw you in the deep end here. Has he mentioned stem cell treatment for dogs? Oh, you don't know what can of worms you've opened here, Denise. What's your feelings? It's your platform today. So how do you feel the world is moving with regards to stem cell?
Well, I mean, it's challenging because there's a lot of hype about stem cells. And, when I was an academic, I did research around stem cells. I'm open-minded, and we've got to be careful we don't throw the baby out with the bathwater. I'll be blunt, there's a lot of nonsense talked about stem cells. Actually defining what is a stem cell is challenging. So I've just been working with some colleagues around producing a paper about the sort of minimal definitions of stem cells. But the evidence at the moment, is what I would describe as weak, but it's emerging. So we should remain open-minded. The difficulty, I think, is that robust clinical trials are lacking. There are some big clinical trials happening in human medicine, which is good because we'll probably learn quite a bit from those because they'll be really well funded. And it's, stem cell therapy in dogs at the moment is a bit of a cottage industry, and therefore there aren't big research and development budgets behind that. And therefore, the evidence is relatively weak at the moment, would be my honest opinion.
And I think people are doing different things. So when you try and bring together different trials or different studies, you can't cross compare. So you can't make that data set bigger. People have done different approaches, different stem cell types, different measuring outcome measures. And so you end up looking at them all individually, and they can all be of very different standards, can't they?
They can. And that's why we've been trying to produce some guidelines around reporting studies on stem cells to make that better. But and also, some systems take fat-derived stem cells, extract them from the fat, spin them down, resuspend them, and actually probably only about 6 or 7% of those cells are stem cells. Other systems will take that cell extract and then culture up the stem cells in the laboratory over a couple of weeks, where you'll end up with a pure population of stem cells and an expanded population of stem cells. So we can't lump those two things together. They're really quite different. And we don't know which is the better approach.
No, lot to learn. I think this was referring to force plate analysis and trying to, so I should imagine that really sums up, it's looking at limb function rather than force plate analysis being a translation of pain. Would that be fair to say? I don't know what, briefly, come back to us if you want us to answer that more. I'm not 100% sure where that question comes from, but come back to us, Ruth. Oh, this is a good one. What about dogs that can't have NSAIDs due to other health conditions? What's your kind of thoughts and support on that?
Yeah, well, I mean, I guess what we haven't had a chance to talk about tonight is that, you know, in the last few months, we've had this brand new avenue of pain relief open up, which is anti-nerve growth factor antibody. That's not a non-steroidal, it's blocking nerve growth factor, and it's using an antibody, which is a protein. So the side effects are, you know, very, well, actually extremely safe, that drug should be. Because it shouldn't affect kidney function or renal function or gastrointestinal tract. I think the only adverse events reported in the trials were some mild skin reactions around the injection site. So it's a subcutaneous injection once a month or so. And so we're all learning with that new product. It's called Librela. Certainly my initial experiences with it have been very good. We've also got another option for dogs that are sensitive to non-steroidals is Galliprant, which is a subset of non-steroidals, but it works in a very specific way. And the gastrointestinal safety of that product appears very good. So that's another option for dogs that are sensitive to traditional non-steroidals. And also using gastroprotectants, other medication to kind of try and block the effects of non-steroidals on the gastrointestinal system is another option. So there are lots of options out there. I'd suggest talking to your vet, but we've never been in a better place in terms of providing pain relief for dogs with arthritis. So it's very exciting. Yeah.
And if you've had a reaction to one non-steroidal, keep an open mind. Many of the pain specialists will be trying 3 or 4 different non-steroidals before they go, okay, fair dues, we'll try a completely different approach. So yeah, 3 or 4 before giving up on non-steroidal family. Oh, you're going to love this one. What is the best way of establishing if something is compensatory issue to OA or a separate issue?
I guess that question is meaning is there a problem elsewhere in the body because of OA in a primary site?
Yeah.
Well, you know, I guess each case would be absolutely different. And, you know, I think speaking to your vet, getting a good clinical examination, and it may be some diagnostic imaging if necessary, you know, and see if there really is a problem there, or is it a compensatory issue? I guess we don't understand these issues very well in dogs because they can't tell us. And muscle pain and spasm are difficult to diagnose.
And I think what's common is common. I got taught that straight out of uni, you know, and if you've got a dog that's got muscle wastage and they're not limb loading in the hind limbs, and then they've got well-developed muscles in the front end and a thick neck and thick shoulders, common is common, you know, hips transferring forward and compensatory issues in the forequarters. But as John said, you know, it's a team approach and just kind of like unwrapping an onion, lifting the layers off to get to the bottom of it. And it might be a case that you only know over time when the compensatory issues start to improve because you're dealing with the primary and they're willing to throw their weight back and start engaging the hindquarters. No, it's not Derek the cat today. It was Alfie the cat. But I've got a 20-year-old cat that keeps jumping in. Yeah. Good question here. After a hip replacement, can OA still develop in that joint?
Well, that's an easy one. No. So, I mean, a hip replacement generally involves cutting away the ball of the hip and putting a new ball on, which is usually a material like cobalt chrome, and it's got a long stem that goes down the femur, usually. And then it also involves reaming out the cup of the hip. So you take a sort of domed blade and spin it round in the cup of the hip, and it takes away all of the joint lining, the cartilage, and some of the bone underneath. And then we put in an artificial cup, which is typically plastic, high molecular weight polyethylene or something like that. Sometimes a material called PEEK is used these days. And so basically the ball and the cup have been replaced. And so there is nowhere for the arthritis to reform. So yeah, that's the end of the story. And you know, hip replacement, I didn't get a chance to talk about it, but generally, a very successful treatment for dogs that are the right candidates for it. And, again, it's another research theme of mine, which is following up dogs we're about to look at a 10-year follow-up of dogs that have had hip replacement, and which has been a national collaboration. So the UK has kind of been leading the way there around the world in terms of follow-up on dogs that have had hip replacement, so that we can make sure we're putting the best type in, and which will last for the longest period.
Yeah, and I think that's been a change in recent years, really. Jamie McClement's listening, just so you know, and I listened to his podcast with the VOA recently, and being much more proactive about using hip replacements earlier in the disease rather than waiting and using it as a salvage surgery, see it as more of a kind of like positive thing. And I know that that's quite a recent change now that we've got more information about how successful they are and how reliable they are. Whereas in previous years, you're like, well, cope as long as you can, and then if we've got no other options. So,
although obviously that's right, I absolutely agree with that. Although I think counselling with owners is very important, because when it goes right, it's brilliant, total hip replacement, but it can still go wrong, even in the best hands, and complications do occur. So we've just been looking at some data of about 1,200 hip replacements, and from multiple centres, and regardless of the experience of the surgeon, complications can still occur. So you've got to be sure it's the right thing for your dog. When it goes right, which it does most of the time, it's brilliant.
Perfect. This one you're going to know a bit about from your little slide at the beginning, having had great involvement with JD. So do you encourage people to go onto a prescription diet? Is that?
I am a named co-inventor of Hill's JD. That's because we did quite a lot of laboratory research to show that essential fatty acids like EPA can inhibit one of the enzymes in cartilage, which degrades cartilage. And so, it's quite an interesting effect there. There is some clinical data to support Hill's JD and other, I believe, other diets with high levels of essential fatty acids, omega-3 fatty acids. EPA in particular seems to be useful. So yeah, I think it can be part of that multimodal management. Of course, one of the issues is the energy density of all those omega-3s. So you've got to be careful about the energy content of the diet. And so Hill certainly tweaked that fairly early on when they realised there was a bit of weight gain going on, because weight gain isn't good for OA. But yeah, I think there's certainly some evidence there. We could do with some more evidence.
Yeah. And if you want to know more about food, we did a brilliant live with Cecilia Villaverde last week talking about how much evidence there is behind inflammatory foods and whether we can start saying, yes, avoid that diet because it's inflammatory. The short answer is no. There isn't anything yet in the dog world to say that's an inflammatory food. Don't introduce that into your dog's diet. What we do know is using the anti-inflammatory nature of certain diets, and that is the marine-based omega-3s. PRP, so VPET, so not stem cell, but platelet-rich plasma, which other people are using. Do you have much use with the VPET or any of those type products?
I mean, I'll have to put my hands up and say I've got no personal experience. PRP and those products, again, we've got the same issues with stem cells, huge variability as to what's in the products and in the studies that go with them. And yeah, again, and even in human medicine, it's very challenging to get a clear signal as to the efficacy of these products. So again, weak evidence base at the moment, emerging, same problem, cottage industry, lack of big, robust clinical trials. Yeah. So it's difficult to give a straight answer to that, really. We just don't know properly.
No. This is a good question. Since drugs like Librela deal with the pain pathway rather than inflammation, should we be given non-steroidals alongside to deal with the inflammation?
What should I say there? Well, I mean, osteoarthritis certainly has an inflammatory component, but it's nowhere near as much an inflammatory component as something like rheumatoid. So it's a relatively non-inflammatory disease. But that's not to say there isn't inflammation. I actually think non-steroidals, a lot of their action is through pain relief anyway. But can we use Librela plus the non-steroidals? Absolutely yes, because they are attacking the pain pathway in different ways. And so I think that's going to happen quite a lot. If dogs need more than just a non-steroidal or more than just Librela, actually combining the two, I mean, it's not a licensed way of using the product, but off-label, I think in theory should be very safe.
Cool. And that's kind of covers Laura's question as well. You know, by losing the non-steroidals, are we losing any disease modification effects? So I know that there's a lot of fear, isn't there, because of the human work. 2015, when they had the rapidly progressing OA, didn't they? And they were like, oh, could it be because those humans were on a non-steroidal and a monoclonal antibody? But I don't think there is any evidence to suggest that yet in dogs.
Not in dogs, but I guess we haven't really looked.
No.
And of course, the trials in human patients went on for years rather than weeks to months.
Yeah.
But yeah, this is very small numbers of people, very small numbers of people that were affected. And it did seem that when non-steroids and the anti-NGF, which is not the same antibody, of course, as Librela, but same target, when they were given together, it seemed to increase that risk slightly. I don't, just go back to the disease-modifying ability of non-steroidals, I don't think there's really any strong evidence for that. Non-steroidals, if anything, in animal models years ago, the older non-steroidals were shown to perhaps enhance the progression of OA a bit because of negative effects on cartilage. The more modern non-steroidals seem to be more neutral on cartilage. So I don't think there's really any strong evidence to suggest that non-steroidals are disease-modifying in osteoarthritis. And for me, they're useful for their pain-relieving effects. Yeah. But
do you use any of the products that are claimed as disease-modifying, such as the pentazam polysulfates, you know, the carchivens and the adequans, and do you buy into that approach at all?
Well, one can make claims about all sorts of things. Actually, hard evidence for disease modification in clinical patients in dogs is completely lacking. And the reason for that is, when I say disease modification, I'm saying, can we slow down the loss of articular cartilage over time? And actually, we can't even measure that in dogs. The only way to measure that in human patients is with high field MRI scans. And canine cartilage is so thin that even with a high field MRI scanner, you can't measure the cartilage thickness or volume, and you don't have the sensitivity to look at change over time. So it's not possible in clinical patients in veterinary medicine.
So much we don't know, isn't it? Right, last question. It's going to be this one. Especially for younger dogs diagnosed with OA, is there any value in conducting repeat x-rays, or is monitoring better achieved using the mentioned questionnaires? Great question.
It's a really good question. And yeah, once you've done your baseline diagnostic imaging, generally, you know, doing imaging to kind of monitor the progression of OA is kind of irrelevant, really. It's more about how's the patient functioning. You know, I guess you'd only do repeat imaging if you were in doubt about the original diagnosis, or you think that something might have changed substantially or materially. So no, I would get the diagnosis with imaging and maybe some other tests to make sure it's OA, and then use the questionnaires and the veterinary examination and all those pieces of the jigsaw together, and decide upon management plans from there, really.
Perfect. I think this has been one of the most informative lives we've had. It's been great. Yeah, loads of people saying thank you, which is awesome.
Well, it's nice people to tune in. Thank you. Yeah.
Oh no, I told you the followers, they've got quite good questions. They know their stuff, and they're like sponges trying to learn more. I'm just going to do a really brief, John is totally okay with this. If you are interested, if you're a canine professional that you really want to understand more about this disease so that you can introduce it into your care plans, you might be a dog walker, a trainer, a pet sitter, a pet shop owner, you might own dog kennels and you're thinking, I need to know more because this is such a prevalent disease. There is a course for you at the bargain price of $180, and it all goes back into CAM. So it's 12 modules. It's RACE approved for 10 hours CPD. It's AMPTRA approved for 44 CPD units, and it is recognized by all of the dog training organizations around the globe. So there you go. 10 top tips, and then I'm going to let you go and you can go and have a glass of wine. I'm going to make it work till the final minutes. So come on then, give us some tips of what you feel is really important. You're going to start, I'm going to start with 10, you do 9, I'll do 8, 7, and then that means number 1, the biggie is yours. So number 10 for me is start building a good working relationship with your vet. Your vet is the prescriber and the diagnoser. It's a hard graft for all people involved, dog owner and vet. So just try and spend a bit of quality time building up a good relationship so that you can use things like the owner questionnaires. You can pop them an email. You can get on the phone and ask them a quick question. Number 9.
All right, we're working up to number 1, are we? Okay. I would say try and be evidence-based. And that's really challenging in OA because there's a lot of almost misinformation out there and lots of claims. And I understand that. But try and go to trusted sources. And there you go, CAMs are great, one of those. So, use CAMs to keep yourself up to date and be evidence-based, because then you'll be using your resources to the best possible, value.
Yeah, definitely. And we're very lucky to have amazing speakers. So, get your gin and tonic, get your cup of tea and go onto our YouTube and just listen. These people have been doing this thing for years, and there's probably 200 to 300 videos on there now of all different elements of managing OA. Number 8 has to be weight control. It has to be weight control. I am the freebie person. Get your foundational free of charge interventions in place. So look at getting your dog's body condition score down to an optimal 4.5, 5 out of 9. If you want to learn more about body condition scoring, we have an email automated series, 6 daily emails learning about weight control. And I'll put a link at the end of this presentation. Number 7.
Okay, we should have checked these before because mine was body weight, but I'm going to make it learn about the impact of body weight on OA. And so education around that. And, there are really robust studies to show that keeping a dog lean is the one disease-modifying therapy that you can invoke. There are lots of studies to show that. It slows down the progression of OA if you keep your dog lean. And animals that are overweight and human patients that are overweight or obese are in a pro-inflammatory state. And so actually there's probably an endocrine link between being overweight or obese and osteoarthritis, as well as a mechanical link. So really important. Really important.
Number 6 has to be my favorite, flooring. I say it every time. I am a veterinary occupational therapist. Not that dogs have proper occupations, but they kind of do. Anyway, flooring, really, really important, guys. And just take the time to watch your dog, looking for slips, trips, stumbles, hesitancy, because that's the world that they're living in for like 99% of the time is in your home. And if they keep having these repetitive slips, trips and falls, it will manifest, it will add up. And it's something that you can quite easily adapt. Number 5.
Okay, my number 5 is monitoring. So with a chronic disease like OA, it's so easy to get used to it and not notice the change. So I would say maybe once every month or every 2 months, use an owner questionnaire and put it in a drawer. Don't look at it, and then do it again in 2 months' time, and then compare your questionnaires, and you'll see if things have changed. So monitor your pet carefully.
Like that. Number 4 is definitely sit down and think about those habits that you have that in your mind you think, oh, that's what makes them really happy. The ball throwing, the chasing the squirrels, the running down the garden after a cat as soon as the back door's open and it's pitch black and they fall down the steps and they go down it so fast, jumping up at the walls, up the walls, up the walls, chasing the postman. All of these things that you're like, oh, but that's what he's always done. These things really stack up. Those high impact torsional repetitive forces really do stack up. You can modify it. You don't have to completely get rid of it. They can carry the ball. You can hide the ball. You can roll the ball. But just have a word with yourself. Sit down with a cup of tea and go, is it absolutely imperative that they still do that activity, which I know is likely exacerbating that disease, or can I modify it and get the best of both worlds? Number 3.
Number 3, I've got to say this, I'm a surgeon. Don't forget surgical options, because they, not always, but sometimes they're the right option, like hip replacement, and can be transformational. So
yeah, I like that one. Number 2 for me is be proactive, not reactive, guys. And that can include many different things. Think about the walk that you're going to go on. Are there ways that you can shorten it? Think about that long weekend hike that you're going to go. Is it right? Think about whether your dog needs a harness now, not later. One of the sad things is when people buy the help them up harness when they have got no strength in their back legs. Wouldn't it be better if they were introduced earlier and it was more of a rehabilitative approach? So be proactive rather than reactive. Number 1.
Number 1, I'm going to sound a little bit like Tony Blair here. Education, education, education. So there's loads of evidence in human medicine to show that education really helps human patients with their OA. And I think it's the same for dogs. Obviously, we're acting as their carer, but if we're educated about the problem, we can provide the best care. So again, coming to resources like CAM will keep pet owners up to date with the best education.
Yeah, and share it. We know as vet professionals that we are now in an era where people are likely to listen to their peers more than potentially the professionals. So if you've got all this wealth of information that you're learning, share it, pass it on so that we can get the appropriate message out there to the majority. Thanks, John. I've been really looking forward to tonight. I've also been terrified because I was like, oh my God, it's going to be like doing my orals again. Being back at the vet school, it's going to test me. It's been brilliant. It's been absolutely, absolutely brilliant. I'm so grateful, and everybody's saying thank you. So it's definitely been a top live that we've ever had. We're going to be back next week, guys. I can't remember. No, I'm back tomorrow with Dr. Amber Batson, and we're talking about pain and behavior. So please tune in tomorrow. And she's been with us twice before and had a great reception. Very, very great speaker. So please come back 7 p.m. Thursday evening. Till then, thanks, John. Really grateful.
Thank you, Anna. Thanks for tuning in, everyone. Yeah. Nice.
Cool. See you later, guys.